Home of Medicine podcast with me, Dr. Amy Burbridge.
And with me, Dr. Ben Lovell.
So Ben, I've got a case and I'm going to go straight into it today.
Okay, let's go.
So this is a case that I have been involved in, but I also want to say a big thank you to a consultant, colleague and friend of mine, because he's taught me a lot about this case and introduced me to the condition. So a massive thank you to Dr. Simon Beattie for helping me with this case.
I'm sensing I'm not going to guess the diagnosis then. It's something that you hadn't heard of before you started, but let's try anyway.
No, I hadn't, but
Okay.
you probably haven't. So I've got a 49-year-old male who presented to hospital with shortness of breath and a cough. He'd had the cough and the shortness of breath for 4 days, and he said that he'd been coughing up some blood at the same time. The blood was bright red, orangey tinge in the sputum. It wasn't the dark sort of browny colour that you can sometimes also see with haemoptysis, and he'd had no previous haemoptysis in the preceding couple of weeks. He'd also lost 4 kilos of weight in 12 months. On further questioning, he said that actually I've had 3 similar episodes of shortness of breath and coughing up blood over the last 12 months. They all last for about 4 to 5 days and then they settle down. Any thoughts?
I wish I had a pen and paper because I need to map this out, but I'll try and do it just on the hoof. So cough with haemoptysis. So initial things I think of there, you can get a little bit of mild haemoptysis with severe chronic coughing if you get a lot of inflammation of the trachea and a little bit comes up, and it doesn't automatically mean disaster if it's sort of it's just a bit of inflammation, a bit of bleeding. But that would be something that I would consider first of all. Is this just a really nasty chest infection / pneumonia with a bit of local irritation, blood coming up? You can get haemoptysis and a cough with some severe forms of pneumonia, such as Klebsiella pneumonia. So I would be keeping infection again at the forefront of my mind here. It's an acute episode of cough. Did you say shortness of breath as well? Yep, shortness of breath, cough, and haemoptysis. You can, of course, get haemoptysis with PE, but it's really big PEs you get it, sort of massive, submassive PEs, and they don't usually make you cough. That's usually pleuritic pain and sudden shortness of breath. And if they're having haemoptysis, a bit of hemodynamic instability is not rare as well. I mean, other conditions which can cause a cough with haemoptysis, bronchiectasis can do it. That's a chronic disease. He's had multiple flare-ups, so maybe he isn't an undiagnosed bronchiectasis, and this is part of it, the waxing and waning of that condition. So chronic inflammation of the lung and dilatation of the bronchioles with lots of mucus and some blood coming up.
Yeah.
And then rarer stuff would be conditions which cause pulmonary hemorrhage, alveolar hemorrhage. So hereditary hemorrhagic telangiectasia, but it'd be very unusual to get to the ripe old age of 49 and have your first presentation of this. And then also pulmonary renal syndromes such as Goodpasture's are incredibly rare. And I'd only really ever think about if there was a coexisting nephritis, so blood in the urine as well, on the urine dip. So I would go in first of all by screening for infection and taking some more history about chronicity. The only other little strand to consider is I think you mentioned some systemic features of weight loss over 4 months. That does speak of malignancy and coughing up some blood. Does he have lung cancer? And this is his first presentation of cancer. So you can get some haemoptysis with primary lung tumors, and that can range from rusty colored sputum to horrendous hemorrhagic haemoptysis if they erode a tumor into a blood vessel within the lung. So a chest x-ray would be very useful from this point of view as well. And that's my opening gambit.
Okay, so you've given me huge numbers of differential diagnoses there. So if you are on a post-take ward round at work and you're given that very brief amount of information that I've just given you, what would be your top 3 diagnoses that you want to rule in or rule out at this point?
Infection, cancer, probably the other way around. Cancer, infection, and then can I do a really nebulous third one? Chronic lung condition of as yet undefined etiology that needs a bit more digging into.
Yeah, so maybe something that you had as childhood. You mentioned bronchiectasis. Did you have an illness that could have led to chronic lung disease that we don't really know about yet?
Pulmonary TB, all these sorts of things.
Okay, TB's another option. Yeah. Okay, excellent. So just as an aside to that, he's actually from Eritrea. but he'd been in the United Kingdom for 12 years. And there was no recent travel in his history. He had a past medical history of ventricular septal defects, aortic regurgitation, stroke, type 2 diabetes mellitus, and angina.
So quite a comorbid 49-year-old.
Yes, there's a lot going on there, isn't it? There. Does that change your differential that we started it at the beginning?
So it could be TB.
Okay.
It could be, and he's had a stroke before, so maybe he's taking a treatment like clopidogrel or another antiplatelet. Yeah,
Yeah, good
yeah.
thoughts. Yeah.
But he's not anticoagulated with a DOAC, say, for atrial fibrillation induced stroke
Right.
emboli before. No. All right then. So maybe he's on clopidogrel, which is thinning his blood slightly. What else? What else? What else? There's evidence of macrovascular. So he's had a stroke before. Did you say MI? No, you said angina. So maybe ischemic heart disease before. So I need to just map out those past medical histories a little bit more and understand what treatments he's had, when he was diagnosed with them. Was there surgery done on this congenital VSD? Aortic regurgitation, does that mean anything to me in this instance? Not particularly, no. But I think I need a bit more about his examination findings
Mhm.
and basic bloods and a chest X-ray really to try and limit my differentials from how wide they are now to something a bit more coherent.
Okay, excellent. So you asked if he was on clopidogrel. Yes, he is on clopidogrel and aspirin.
Mm.
For his angina, he's also on a GTN spray that he takes as and when he needs it, and also isosorbide mononitrate and a beta blocker. For type 2 diabetes, he's on metformin and has been on that for a long time. That's really the only medication that he takes, and a statin that he's on as well, atorvastatin, 80 milligrams at night. Now, on examination, he's not short of breath at rest. He actually looks well. So when you stand at the end of the bed, you think, actually, he looks well. He doesn't look cachectic. So I know that you mentioned malignancy. And when I think of malignancy and hemoptysis, I do also think of lung malignancy. And normally that indicates that the malignancy is potentially advanced and they look quite unwell. And you can often tell when a patient has malignancy, but this gentleman looked incredibly well. Although he said he lost weight, he didn't look underweight or cachectic. His observations were completely normal. His oxygen saturations were 98% on room air. He didn't need any oxygen. His blood pressure was completely stable. Heart rate was 80 beats per minute and regular. There was no atrial fibrillation noted, and his temperature was 37.4. So nothing really of note in that. So he's on examination of his chest. He had coarse creps at the right base, but the rest of his chest was clear. You couldn't auscultate any wheeze or any other crepitations throughout the rest of the chest. When you auscultated the heart, he had a systolic murmur and a diastolic murmur. Now, if we go back, he does have a ventricular septal defect and aortic regurgitation. So there was a lot going on from the murmur perspective and what you could actually hear at that time. Abdomen was soft and non-tender. There was no pedal edema noted. There was no jaundice. He didn't look particularly pale. So you mentioned bloods and a chest X-ray. Are there any particular bloods that you'd like me to give you?
There are, but before I ask, was he clubbed?
Ooh, why do you ask that question?
Clubbing is a sign of, well, it's associated with lung cancer, but it's also associated with chronic suppurative lung conditions like bronchiectasis.
Mhm. Yeah, so he wasn't clubbed.
Okay. And was he a smoker?
Non-smoker, never smoked.
Right. Okay. All right. So you asked me about blood tests I want. So let's start off with the basics. FBC, he is not anemic. His bone
So,
marrow is working.
so his hemoglobin was 110.
Low. Okay. Not
So although he
desperately.
looked well, although he didn't look particularly unwell, his hemoglobin was a little bit on the lower side.
Yeah. Okay. Platelets and blood cells, white blood cells.
White cell count 13.7, neutrophils 9.82, platelets 544.
So slightly up, but not in a diagnostic way. And he's
Mhm.
got a good white cell count. So his bone marrow is working. Now his HB is slightly low. Was it microcytic, normocytic, macrocytic?
It was normocytic.
Okay. All right then. So nothing too red flag related there. What about his biochemistry? So were his reunions normal?
Completely normal.
Okay. CRP,
94.
so elevated. All right then. So they're the main blood tests that I want. Do I want anything? I don't think I really have an indication to look at his liver function tests or his thyroid profile or his bone chemistry. Were those available?
Yeah, so just to ask, given the fact that he'd had some hemoptysis, would that prompt you to check his liver function?
Only in the roundabout way of, is he got hemoptysis because he's profoundly coagulopathic? His INR, his PT was very prolonged because he had liver disease and he was not creating coagulation factors. So yes is the short answer, but that's the long answer.
Okay.
Yeah.
So liver function tests were done because of the reason that you said, and they were completely normal. And
Yeah.
I think his prothrombin time was normal as well.
Clotting was normal. Okay. All right then. So I think that's really decent blood test there for me.
Mhm.
Chest X-ray, I'm really intrigued by.
So the chest X-ray showed some consolidation at the right base.
Okay. So, I mean, I'm starting to think we've got some really compelling markers for pneumonia. We have a man with a short history of a cough. He has got a bit of hemoptysis, which is unusual for pneumonia, but he's got a cough, he's got crackles at the right base, and he's got consolidation at the right base, and an elevated CRP of 94.
Mhm.
So I think pneumonia is a good differential here. Whether it's the only differential is we're not there yet, but it's a good place to start. So at this point, I would be saying when I was doing my sort of problem list, one, consolidation or community acquired pneumonia, and my plan number one would be start antibiotic treatment for that.
Okay.
I'm not necessarily going to stop thinking now, but I dropped my first anchor in diagnosis bay, and that's where I'm going to drop it.
Okay, so you're going to go for community-acquired pneumonia.
Yeah.
How are you going to treat him? You're going to give him oral antibiotics or IV antibiotics?
Okay, so putting aside now all the other issues, but in generally, how do I treat pneumonia? So there is, of course, the CURB 65 score, which risk stratifies people due to an acronym of confusion, their urea, respiratory rate, their blood pressure, and their age. So a CURB 0 and a CURB 1, I think, oral amoxicillin all the
Mhm.
way. A CURB 2, you have the option of adding in a macrolide, that's clarithromycin, and I think 3 and 4, that's when you consider IV antibiotics. And in my trust, he would be admitted and given IV cefuroxime, I think. And he is someone who is young, who has got a normal respiratory rate and blood pressure, is not confused. Even his urea was slightly high, his COPE score is low. So actually, you could ambulate him with oral amoxicillin and avoid an admission in this
Mhm.
particular case.
Yeah, absolutely. So that's always a thought, isn't it? He's young, his curb scores is scoring 0 actually on the curb score. He has got multiple comorbidities, which
Yeah.
when I see those, I always get a bit more twitchy because he's young and he's had a stroke and with the aortic regurgitation. And I think, is that a reason to therefore admit him or not? I guess it depends on your gut instinct on the day as well, isn't it? As to how you see the patient potentially.
I think so. I think gut instinct and end of bedogram has a lot to do with it. But
Mm,
I think on the face of it all, even with those comorbidities, if he was not requiring oxygen or therapy or intravenous therapy, then if we could see him tomorrow morning in
yeah.
ambulatory care, and that's very robust safety netting, and we say, and if anything happens in the meantime, the ED is open 24/7, so always come back. And younger patients, you can safety net them like that because they are able to make their way to help if they need to. So I think he's got a reasonable safety net there, and I think even with the comorbidities, you'd have a good argument for ambulating him and seeing him sooner rather than later in some kind of STEC ambulatory care setting.
Okay, so you've got a gentleman who's had some hemoptysis and
Yeah,
you think he's got pneumonia. So you think this is an infective cause.
yeah.
What do you now do to try and find out what infection is causing the pneumonia? Do you do anything or do you just give antibiotics and hope that it goes?
Okay. In reality, very often we treat empirically, and especially if we're discharging them, and we often give the follow up to the patient and say, if you don't feel better, our hospital has something called the 7-day safety net phone number where they can ring it and bypass GP and bypass calling ambulance within 7 days of discharge, and that comes through to our ambulatory care, and we can bring them in for review. So I often give it to them and say, oh, we're not planning to see you again. Here are your antibiotics, and you should get better. I don't often do phone calls for symptom reviews via our ambulatory care phone clinic. I say, but you call us if you have a concern. But if someone's producing a lot of sputum, then you can always get a sputum culture, which is really useful for guiding, especially if they're prone to recurrent infections. So if someone has COPD, it's really useful to know that when they last presented with an exacerbation, their sputum grew Haemophilus, which was
Okay.
sensitive to amoxicillin, or resistant to amoxicillin, and they needed doxycycline, for example. So that is useful in recurrent attenders with a similar issue over time. If someone is not producing much sputum, I certainly don't try and induce it by doing things like giving them a saline neb and some chest fees to try and bring some up. If there's no sputum to come, then who am I to force it and drown the patient in nebulizers to try and induce it, unless I'm looking for TB.
Okay, yeah, absolutely. So you could do sputum cultures, like you mentioned, if it's, there's lots of sputum coming out, and that can be incredibly helpful to identify if they're going to grow something. You also mentioned TB. So how would you test for TB in the acute department practically? How would you do that?
That's really interesting because there aren't many acute tests you can do for TB. We do a chest x-ray and you look for what is classically apical consolidation, because that TB loves the highly oxygenated apex of the lung. So there's sort of radiographic markers, not diagnostic markers, but markers. And then you try and get 3 sets of sputum culture for acid-fast bacilli, which is sometimes easier said than done. When I was doing my acute medicine training, I spent some time as a respiratory reg, and we would give patients in outpatient clinics sputum pots and say, please, can you drop these off next week? As much sputum as you can in each one, and we'll call you with the results. But that was a diagnosis that was made over weeks rather than there and then. And in acute medicine, we're used to same-day test result. So that's it really that I can think of. Now, there are cleverer tests, but they're way outside what I would do as an acute physician. So
Yeah.
looking for thick and for smears and things outside acid-fast bacilli staining.
Absolutely. So just to go back to your chest x-ray findings, which you said, I seem to remember at medical school, I know we remember random things sometimes, it was called a GON focus.
Yeah.
You remember that? And it was spelled
Yeah.
Ghon.
Yeah. Gorn. It sounds German, right? Gorn
GON
focus.
focus, yeah. And it's like
I
a
see.
collection of macrophages, wasn't it?
Yes.
That had created that. So yeah, you're right. You could see the typical findings on a chest x-ray. You might do some acid and alkali fast bacilli, which can be incredibly helpful. Or you may do a sputum culture if you're trying to look for other infections. Absolutely. So just say this is bog standards. No, I shouldn't say bog standard because pneumonia is awful. But let's say this is pneumonia and you're sending the patient home. How would you follow the patient up? Apart from your get in touch if there's a problem, is there anything that you would do
You mean in general or with this patient?
with in general with somebody with pneumonia with chest x-ray findings?
Okay, so if they're over the age of 50 or have a strong smoking history, then you're supposed to get a follow-up chest x-ray in 6 weeks to check for resolution of the consolidation, make sure there wasn't an underlying malignancy, which is difficult to arrange. I know every hospital has their own way of trying to manage that, and it's a subject of intense audits and QI projects wherever you go. So there's looking for the 6-week follow-up x-ray, which you don't need on everyone, just higher risk people. So that's one thing for it. Otherwise, as I said, I tend not to ring people to check they're feeling better if they're young and have got the wherewithal to monitor their own health status.
So I do chest x-rays on everybody who's got consolidation on a chest x-ray after 6 weeks. And I'm probably not doing the right thing, but the reason I do that is because when I was a registrar, I picked up a malignancy in a patient who'd had pneumonia. When we rechecked the chest x-ray, the changes hadn't disappeared, so we did a CT and there was a malignancy within there as well. And again, we often talk about bias and retrospective bias and hindsight bias and whether it's right or wrong. Really, ever since then, I have done a chest x-ray. Some people maybe not, the young, very young ones who I'm happy that they've got better, but that's something that I do. Okay, so you're probably thinking, why is she talking about this case?
Before you go any further, you just raised an interesting point. CT is actually good. We hadn't mentioned that. So cross-sectional imaging of the chest you can do in someone you've admitted if you think it's more than a consolidation. If you want to look for signs of TB, sometimes they can pick up some things like radiographic signs on a CT scan, which can actually help you more towards that diagnosis. And of course, you can do it in someone with pneumonia if you think there could be a strong suspicion of malignancy as well, and that's really useful. So I haven't mentioned CT before as an inpatient sort of same-day test you could think about.
Yeah, and you also mentioned bronchiectasis early on. So again, you may be thinking about high resolution CTs if that's the diagnosis you were going down. And we also mentioned pulmonary embolisms way down the line. You said, I guess at that point, if that was a high suspicion, you would think about doing a CTPA. One thing that you mentioned that I right back to the beginning was that you said that Patients who have hemoptysis in a PE, it's when the PE's big. It's a
Mm.
massive or a massive PE. However, I remember being taught, and it's still in textbooks now, that you should always ask a patient who's you think's got a PE whether they've got hemoptysis or not.
Mhm.
And I think that is relevant, but also if they have got hemoptysis, it doesn't necessarily mean they've got a massive PE. And if they haven't got hemoptysis, it doesn't mean that they haven't got a PE. So I don't think it's a very good discriminator as part of the history taking.
And to add to that, I admitted a patient last week who had hemoptysis and had bilateral PEs, which were not massive or submassive. So it's not a hard and fast rule.
It's not, is it? It's one of those things that it's a bit nebulous, isn't it? It's just very difficult to
Yeah.
somebody's got it or they haven't got it. I wouldn't necessarily say they haven't or haven't got a PE. Okay, so we did some sputum cultures on this gentleman, and these things can take a little while to come back.
Yeah. Yeah.
And when they did come back, first of all, we did TB, and it said there was no acid and alcohol fast bacilli seen at all on 3 samples. So we were
Good.
pleasantly, we were really happy that this wasn't TB. Although I have to say that initially that was probably the prime differential diagnosis.
Right.
So the sputum culture grew. Now I'm probably going to say this completely wrong.
Go on.
Serratia marcescens.
Okay.
Have you heard of that?
I've heard of Serratia. Yes. I can't lie and say I've heard of all the
No.
subgenii
So
of it.
So what Serratia marcescens is it's a gram-negative rod,
Mm-hmm.
a bacterium infection that causes pseudo-hemoptysis.
Okay, this is new learning for me. So please go on.
Exactly. So it's found in damp bathrooms. It's found in damp areas, so maybe where there's mold growing or where there's lots of cold, moist areas. And you can see it growing on soap and on bread when it goes moldy, and it gives it a red and orange discoloration. And this is because this type of serratia produces a red pigment. And this red pigment, called prodigiosin, I'm terrible at pronouncing these, prodigiosin, which actually looks like blood. So
Wow.
when patients present with hemoptysis, we have to actually ask the question, is it hemoptysis or is this pseudo-hemoptysis? And could this be Serratia marcescens that is causing a pneumonia?
Did you guys get pictures of their sputum by any chance? Someone should write this up. This would be a great case report for one of the residents to write
Really
up or something.
interesting. Yeah. So, and it's very difficult to treat because of antimicrobial resistance, because it's been around for years and years and years and years, and we don't think about it, do we? I'd been a doctor for many, many years before I'd even heard of this condition, to be honest. And it's the first time that you've heard about it today. So, there may be patients out there who do have pneumonia and hemoptysis, and they've actually got this bacteria rather than anything else. So eventually, the only way that we could treat this gentleman was with ciprofloxacin, linezolid, and gentamicin. So it really needed a big cocktail of antibiotics before it actually disappeared.
So you admitted it.
Exactly. Well, do you know what's really? We did admit him initially. He was admitted initially anyway because of the comorbidities and everything that was going on. And usually with sputum cultures, it can take 48, 72 hours, sometimes long, for them to come back. And he'd been on just the normal antibiotics for pneumonia before we actually grew the serratia. And then obviously we needed microbiology and infectious disease advice as to how we manage it.
So, and you grew you discovered this ratio on a blood culture, did you say?
On a sputum culture.
Oh, on a sputum culture. Gotcha.
Yeah.
Okay,
Yeah.
fine.
So
any markers that you could, like, so when we're looking at cases, is there anything that points towards serratia infection apart from the discolored sputum that we could think about? Is it the infection? It's like really.
Not necessarily, because it is still quite unusual. It's all in their history taking. So are they working in a particularly cold, damp area?
Right.
Do they live in damp housing?
Yeah.
Have they noticed? And it has the classic sort of orange changes on the soap and on the walls, in your shower, and the ceilings. There may be these orange-red marks, which could indicate the serratia. I've never ever asked a patient whether they've got red or orange marks on their shower, but it is one of those diagnoses that you make, I think, when you've gone through all of the other you massively know that haemoptysis isn't massive haemoptysis, that they haven't lost more than 600 mils of blood in 24 hours, and you're happy that it isn't a PE bronchiectasis. So it's very difficult to make, probably on admission. I mean, it'd be a bold diagnosis on admission, but
I'm looking at photos on I'm just Google serratia. I was looking at it, and it looks an awful lot like the sort of just discolored rusty things like you get in many showers. And I'm just wondering whether I've got a bathroom full of serratia now. It looks just sort of like discoloration you see in a lot of bathroom areas. Okay, interesting.
Yeah.
The word pseudo haemoptysis has never been in my lexicon before, and now it is.
Yeah, isn't it interesting?
I think so. I think it's a great little case, even for just if someone published it as interesting photos in clinical medicine, just a little picture of the sputum saying, and a bit of the vignette of the history, and then a little bit about serratia. It's a lovely little publication for somebody who was of that mind.
Yeah, isn't it? I think it's a great case just to get us thinking about causes of haemoptysis, which we talked about at the beginning, but also it may not be coming from the lungs. It might be coming from the lungs, but it might be an infection, and an unusual infection, such as serratia.
Okay, duly noted.
Yeah.
Thank you very much. What an interesting case. What an interesting microbe.
Isn't it just? I know. And I think what I'll try and do is when we put the podcast out is maybe put a link to some pictures that people could have a look at to see how closely similar it is to haemoptysis and what it looks like on soap and in corners and showers and that sort of thing. That'd be incredibly helpful.
Yeah, good idea. I mean, people could always Google it as they listen, but I know a lot of people listen to us in the car or whilst running. So safety first, people. Get home and press the button, the link.
Absolutely. So one key learning point. What are you going to take away from this, Ben?
I think the existence of serratia. Now, hang on, don't tell me. I wrote it down. Serratia marcescens. And the existence of pseudohaemoptysis in a patient who has the features of a severe atypical, i.e. a gram-negative pneumonia with some systemic changes and weight loss, who hasn't got TB and is bringing up something which looks a bit like blood. It'll be in the differential moving forward.
Yeah, absolutely. And it's interesting, if you look at serratia causing infections in the immunocompromised, in some people it can cause osteomyelitis, it might cause septic arthritis, potentially endocarditis if you are severely immunocompromised, particularly in intravenous drug users. So it's always worth thinking about.
Thank you very much.
Thanks, Ben, for all of your knowledge as usual. A massive thank you to everybody for listening. We are growing in numbers every single episode. So I would please encourage you all to rate the podcast on whichever podcast listening service you use, to review us and to share and to subscribe, because the more people who subscribe, the more people know about us and the more people who listen. Massive thank you to everybody. Thanks for listening. Goodbye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.